Welcome to this comprehensive lecture on bronchiectasis in children on the Pediatric Case review. Today we will explore how to recognize, investigate, and effectively manage pediatric bronchiectasis. This presentation is structured around 12 case-based multiple-choice questions to reinforce learning and clinical application. We will cover key aspects including clinical presentation, examination findings, pathophysiology, diagnostic investigations, and treatment strategies. Throughout this lecture, we will focus on practical, evidence-based approaches to help you master this important pediatric respiratory condition. Each question will challenge your clinical reasoning, followed by detailed explanations to deepen your understanding. Let us begin our journey to better understand this disease. Let us begin with our first case. A 7-year-old child presents with a chronic daily wet cough that has persisted for more than 8 weeks. The cough is particularly worse in the mornings and produces yellow-green sputum. The child has experienced 3 episodes of respiratory infections requiring antibiotics over the past year, and the parents report poor weight gain. The question asks, what is the most likely diagnosis? The options are Option A, bronchiectasis. Option B, protracted bacterial bronchitis. Option C, asthma. Option D, habit cough. Please take a moment to consider your answer before we proceed to the explanation. The correct answer is Option A, bronchiectasis. The hallmark symptom of pediatric bronchiectasis is chronic wet or productive cough lasting more than 8 weeks. This case demonstrates several classic features, including daily sputum production, recurrent respiratory infections or exacerbations requiring antibiotics, and failure to thrive indicated by poor weight gain. While protracted bacterial bronchitis can present with chronic wet cough, it typically responds well to a single course of antibiotics and resolves completely, unlike bronchiectasis, which is persistent and characterized by structural airway damage. The diagnosis must be confirmed with high-resolution computed tomography imaging. Early recognition is crucial as timely treatment can halt disease progression and sometimes even reverse mild bronchiectasis in children. Now let us consider our second case. A 10-year-old child with a long-standing history of wet cough comes for evaluation. On physical examination, you auscultate bilateral crackles and intermittent wheeze over the lung fields. You also notice digital clubbing of the fingers. The vital signs are stable, and there is no respiratory distress at rest. The question asks, which of the following is the most characteristic examination finding suggesting chronic suppurative lung disease? The options are Option A, digital clubbing. Option B, inspiratory stridor. Option C, localized egophony only. Option D, normal chest examination. Please consider which finding is most indicative of chronic lung disease. The correct answer is Option A, digital clubbing. Digital clubbing is a highly characteristic sign of chronic suppurative lung disease, including bronchiectasis. It reflects long-standing hypoxia and chronic inflammation. On examination, children with bronchiectasis commonly have crackles or crepitations on auscultation, which may be persistent or intermittent. Wheeze can also be present due to airway narrowing and mucus plugging. Other important examination findings to assess include signs of chronic sinusitis, such as nasal polyps, evidence of failure to thrive with poor growth parameters, and respiratory distress during exacerbations. A thorough upper airway examination is important as chronic otitis media and sinusitis often coexist with bronchiectasis, especially in conditions like primary ciliary dyskinesia. Let us examine the third case focusing on pathophysiology. A 6-year-old child had severe pneumonia at 18 months of age. Now the child presents with persistent wet cough and frequent respiratory exacerbations despite treatment. The parents want to understand what is happening in their child's lungs. The question asks, what is the key pathophysiological mechanism underlying bronchiectasis? The options are Option A, impaired mucociliary clearance with infection and inflammation creating a vicious cycle. Option B, immune complex deposition in airways. Option C, isolated airway hyperreactivity. Option D, alveolar hemorrhage. Please think about the fundamental mechanism that perpetuates this disease. The correct answer is Option A, impaired mucociliary clearance with infection and inflammation creating a vicious cycle. As shown in the visual diagram on the right, bronchiectasis follows Cole's vicious cycle hypothesis. It begins with an initial insult such as severe pneumonia or tuberculosis, which leads to impaired mucociliary clearance. This allows bacterial colonization, particularly with organisms like Haemophilus influenza, Streptococcus pneumoniae, and Moraxella catarrhalis. The bacterial infection triggers intense neutrophilic inflammation, leading to release of proteases, including neutrophil elastase. These proteases cause progressive airway wall damage and permanent bronchial dilatation. The dilated airways accumulate mucus, creating mucus stasis, which perpetuates the cycle by promoting further bacterial colonization. This self-perpetuating cycle leads to progressive lung damage if not interrupted with appropriate treatment. Now for our fourth case regarding diagnostic investigations. An 8-year-old child has chronic wet cough and recurrent respiratory infections. A chest X-ray was performed and showed nonspecific findings. The clinician suspects bronchiectasis and wants to confirm the diagnosis. The question asks, what is the best test to confirm the diagnosis of bronchiectasis? The options are Option A, high-resolution computed tomography of the chest. Option B, chest magnetic resonance imaging. Option C, repeat chest X-ray in 6 months. Option D, spirometry only. Please consider which investigation provides the most accurate diagnostic information. The correct answer is Option A, high-resolution computed tomography of the chest. High-resolution computed tomography is the gold standard for diagnosing bronchiectasis in children. Chest X-rays have low sensitivity, detecting only about 50% of cases and often appear normal in mild disease. High-resolution computed tomography has sensitivity exceeding 95% and can detect early disease. The key radiological features include bronchoarterial ratio greater than 0.9 in children, lack of normal bronchial tapering toward the periphery, bronchial wall thickening, mucus plugging creating tree and bud appearance, and mosaic attenuation due to air trapping. The scan should be performed when the child is clinically stable to avoid overdiagnosis. Multi-detector computed tomography with thin slices provides optimal anatomical detail while minimizing radiation exposure. Let us proceed to the fifth case, focusing on etiology. A 3-year-old child living in a low-resource setting had severe pneumonia at 1 year of age, requiring hospitalization. Now the child presents with chronic wet cough and failure to thrive. There is no family history of similar conditions. The question asks, what is the most likely etiology of bronchiectasis in this child? The options are Option A, post-infectious. Option B, cystic fibrosis. Option C, primary ciliary dyskinesia. Option D, chronic foreign body aspiration. Please consider the epidemiology and common causes based on the setting and history. The correct answer is Option A, post-infectious. Globally, post-infectious bronchiectasis is the most common cause, particularly in low-resource settings and indigenous populations. Severe pneumonia, measles, pertussis, and tuberculosis are major risk factors. In contrast, cystic fibrosis is the most common cause in high-income countries. The imaging comparison table shows why proper diagnosis is essential. Chest X-ray has only 50% sensitivity and may miss early disease, while high-resolution computed tomography has over 95% sensitivity and is the gold standard. High-resolution computed tomography identifies the bronchoarterial ratio greater than 0.9, signet ring sign, and lack of tapering. Although it involves higher radiation, it defines disease extent and severity accurately. All children diagnosed with bronchiectasis should undergo comprehensive evaluation to identify underlying causes, including sweat test, immunological workup, and ciliary function testing when indicated. Now let us consider the sixth case. A 12-year-old child with known bronchiectasis presents with increased cough, purulent sputum, and streaks of blood in the sputum for 2 days. The child is afebrile but reports increased fatigue. Vital signs are stable with oxygen saturation of 96% on room air. The question asks, what is the next best step in management? The options are Option A, start empiric oral antibiotics and send sputum culture. Option B, urgent bronchoscopy. Option C, initiate anticoagulation therapy. Option D, observe only without intervention. Please think about the appropriate initial management for this presentation. The correct answer is Option A, start empiric oral antibiotics and send sputum culture. Small volume hemoptysis, characterized by blood-streaked sputum, is common during acute exacerbations of bronchiectasis and is caused by inflammation and infection of the damaged bronchial walls. The first-line management is to treat the underlying infection with appropriate antibiotics covering typical pathogens such as Haemophilus influenza, Streptococcus pneumoniae, and Moraxella catarrhalis. Sputum culture should be obtained to guide antibiotic therapy and detect organisms like Pseudomonas aeruginosa. Urgent bronchoscopy is reserved for massive hemoptysis exceeding 100 milliliters in 24 hours or hemodynamic instability. Anticoagulation would be contraindicated in active bleeding. Most cases of small volume hemoptysis resolve with treatment of the acute exacerbation, though persistent or recurrent bleeding warrants further investigation. Let us examine the seventh case about imaging criteria. A 9-year-old child undergoes high-resolution computed tomography for suspected bronchiectasis. The radiologist reports a bronchoarterial ratio of 1.1, lack of normal bronchial tapering, and mucus plugging in several airways. The clinician reviews the pediatric diagnostic criteria. The question asks, which statement is true regarding bronchiectasis diagnosis in children? The options are: Option A, a bronchoarterial ratio greater than 0.9 suggests bronchiectasis in children. Option B, the adult cutoff of 1.5 applies to all ages. Option C, computed tomography cannot definitively diagnose bronchiectasis. Option D, the scan should be performed during acute exacerbation. Please consider the specific pediatric diagnostic criteria. The correct answer is Option A. A bronchoarterial ratio greater than 0.9 suggests bronchiectasis in children. Pediatric diagnostic criteria differ importantly from adult criteria. Research has shown that a bronchoarterial ratio above 0.9 in children undergoing awake computed tomography is abnormal and indicates airway widening consistent with radiological bronchiectasis. Adult criteria typically use a cutoff of 1.0 or greater. Other important high-resolution computed tomography features include lack of normal tapering of bronchi toward the lung periphery, signet ring sign, where the dilated bronchus appears larger than its accompanying pulmonary artery, bronchial wall thickening, mucus plugging creating tree and bud opacities, and mosaic attenuation reflecting air trapping. The scan should ideally be performed when the child is clinically stable to avoid overdiagnosis, as transient bronchial dilation can occur during acute infections. Now let us discuss the 8th case regarding treatment. An 8-year-old child with bronchiectasis presents with acute increase in wet cough, fever of 38.5 degrees Celsius, and increased purulent sputum production. The child has no history of Pseudomonas aeruginosa isolation and no drug allergies. Sputum culture is sent. The question asks, what is the best empiric oral antibiotic choice while awaiting culture results? The options are: Option A, amoxicillin clavulanate. Option B, single-dose azithromycin. Option C, doxycycline. Option D, oseltamivir. Please consider the most appropriate empiric coverage for acute exacerbation. The correct answer is Option A, amoxicillin clavulanate. For acute exacerbations of bronchiectasis in children without prior Pseudomonas aeruginosa colonization, amoxicillin clavulanate is the preferred first-line empiric oral antibiotic. It provides excellent coverage against the 3 most common pathogens: Haemophilus influenza, Streptococcus pneumoniae, and Moraxella catarrhalis. The clavulanate component overcomes beta-lactamase resistance commonly found in these organisms. Treatment duration is typically 14 days for exacerbations, longer than for routine respiratory infections. Antibiotic selection should be tailored based on local resistance patterns, previous culture results, and patient allergies. If Pseudomonas aeruginosa has been previously isolated, ciprofloxacin or anti-pseudomonal beta-lactams should be considered. Azithromycin monotherapy is inadequate for acute exacerbations, though it has a role in long-term prophylaxis. Sputum culture results should guide definitive therapy adjustments. Let us examine the 9th case about prevention strategies. A 9-year-old child with bronchiectasis has experienced 3 or more exacerbations per year despite regular airway clearance physiotherapy. The child has no history of Pseudomonas aeruginosa colonization, and an electrocardiogram shows normal QT interval. Screening for non-tuberculous mycobacteria is negative. The question asks, what is the next appropriate step in management? The options are: Option A, initiate long-term azithromycin therapy. Option B, prescribe high-dose inhaled corticosteroid alone. Option C, start continuous amoxicillin therapy. Option D, discontinue airway clearance physiotherapy. Please consider evidence-based preventive strategies. The correct answer is Option A, initiate long-term azithromycin therapy. Evidence from randomized controlled trials demonstrates that long-term macrolide antibiotics, particularly azithromycin, significantly reduce exacerbation frequency in children with bronchiectasis. The typical regimen is azithromycin given 3 times weekly for at least 6 months. Before starting therapy, important screening includes electrocardiogram to assess QT interval prolongation risk and testing for non-tuberculous mycobacteria to avoid creating resistance. The mechanism involves both antimicrobial and anti-inflammatory effects. Benefits include reduced exacerbations, improved quality of life, and potentially slower lung function decline. Monitoring includes periodic hearing assessments and surveillance for antibiotic resistance, particularly in Streptococcus pneumoniae. Side effects may include gastrointestinal symptoms and rarely cardiac arrhythmias. Airway clearance should always be continued as the foundation of management. Long-term azithromycin is recommended as adjunctive therapy for children with frequent exacerbations. Let us discuss the 10th case about complications. A 14-year-old adolescent with bronchiectasis shows declining spirometry values over the past year. A recent sputum culture grows Pseudomonas aeruginosa for the first time. The child is clinically stable at present. The question asks, what is the optimal management strategy for this new finding? The options are: Option A, early eradication protocol with anti-pseudomonal antibiotics. Option B, ignore the finding if the patient is asymptomatic. Option C, start macrolide monotherapy only. Option D, prescribe systemic corticosteroids only. Please consider the significance of new Pseudomonas colonization. The correct answer is Option A, early eradication protocol with anti-pseudomonal antibiotics. Pseudomonas aeruginosa colonization is a major prognostic indicator in bronchiectasis, associated with accelerated lung function decline, increased exacerbation frequency, and worse long-term outcomes. When Pseudomonas is isolated for the first time, early aggressive eradication therapy should be initiated immediately, even in clinically stable patients. Eradication protocols typically include intravenous or oral anti-pseudomonal antibiotics, such as ciprofloxacin or ceftazidime, for 2 to 3 weeks, often followed by inhaled tobramycin or colistin for 3 months. The goal is to eliminate Pseudomonas before it establishes chronic biofilm-protected infection, which becomes extremely difficult to eradicate. Specialist respiratory follow-up is essential to monitor eradication success with repeat cultures. If eradication fails and chronic colonization develops, ongoing suppressive therapy may be required. Early intervention offers the best chance of preventing the accelerated disease progression associated with chronic Pseudomonas infection. Now let us consider the 11th case about associated conditions. A 5-year-old child presents with chronic wet cough and recurrent respiratory infections. The history reveals neonatal respiratory distress, chronic otitis media requiring multiple sets of grommets, and the mother mentions the child has dextrocardia with situs inversus. Physical examination confirms the cardiac findings. The question asks, what is the best diagnostic approach to confirm the underlying condition? The options are: Option A, low nasal nitric oxide measurement with ciliary ultrastructure analysis or genetic testing. Option B, sweat chloride test only. Option C, alpha-1 antitrypsin level. Option D, methacholine challenge test. Please consider which underlying condition fits this clinical picture. The correct answer is Option A, nasal nitric oxide screening followed by ciliary ultrastructure or genetic testing. The clinical presentation of situs inversus, chronic otitis media, and chronic wet cough is the classic triad of Cardigan syndrome, a subset of primary ciliary dyskinesia. Primary ciliary dyskinesia results from genetic mutations affecting ciliary structure and function, leading to impaired mucociliary clearance. The characteristic features include neonatal respiratory distress, chronic rhinosinusitis, recurrent otitis media, and bronchiectasis. Approximately 50% have situs inversus totalis or dextrocardia. Diagnostic evaluation begins with screening nasal nitric oxide measurement, which is characteristically very low in primary ciliary dyskinesia. Confirmatory testing includes high-speed video microscopy of ciliary beat pattern, transmission electron microscopy for ultrastructural defects, and genetic testing for known mutations. Early diagnosis is crucial as it guides targeted management, including intensive airway clearance, prompt treatment of infections, and genetic counseling for families. Recognition of this underlying condition helps explain the bronchiectasis and directs comprehensive care. Let us examine the final case about comprehensive management. A 6-year-old child with stable bronchiectasis attends a family education visit. The parents want to understand the most important daily home management strategies to prevent disease progression. The question asks, what is the core component of home management for bronchiectasis? The options are: Option A, regular chest physiotherapy with positive expiratory pressure devices or active cycle of breathing techniques. Option B, routine codeine for cough suppression. Option C, complete bed rest and activity restriction. Option D, fluid restriction to reduce mucus production. Please consider evidence-based home management approaches. The correct answer is Option A, regular chest physiotherapy with positive expiratory pressure devices or active cycle of breathing techniques. Airway clearance is the cornerstone of bronchiectasis management at all ages. Daily chest physiotherapy helps mobilize and clear mucus, reducing bacterial load and inflammation. Techniques include active cycle of breathing, positive expiratory pressure devices, oscillating positive expiratory pressure devices, and autogenic drainage. The method should be individualized based on age, preference, and effectiveness. Sessions should be performed at least once daily, increasing to twice daily during exacerbations. Other essential management components include adequate hydration to keep secretions thin, regular physical activity, and exercise which promotes natural airway clearance, vaccination including annual influenza and pneumococcal vaccines, prompt recognition and treatment of exacerbations, and management of underlying conditions. Hypertonic saline inhalation may benefit selected patients by enhancing mucus clearance. Cough suppressants like codeine should be avoided as cough is a protective mechanism. Comprehensive multidisciplinary care significantly improves outcomes and quality of life for children with bronchiectasis. Before we conclude, I want to tell you about our exclusive Pediatric Case review community on Patreon. This is a valuable resource designed for dedicated learners like you. When you join our community, you gain access to all our educational videos organized systematically by medical system, making it incredibly easy to find exactly what you need. Whether you are studying cardiology, respiratory, or any other system, everything is arranged for efficient learning. Additionally, all presentation slides used in our videos are available for download as high-resolution images, allowing you to read them offline, take notes, and practice the multiple-choice questions at your own pace. This resource is perfect for exam preparation and ongoing medical education. If you are interested in joining and want more details about subscription options, simply type a comment below this video, and we will personally message you with all the information you need. We look forward to welcoming you to our learning community. Thank you for joining this comprehensive lecture on bronchiectasis in children. Let us review the key takeaways from today's session. First, early recognition is crucial. Always suspect bronchiectasis in children with chronic wet cough lasting more than 8 weeks, especially with recurrent infections. Second, confirm the diagnosis with high-resolution computed tomography, which is the gold standard, and remember that pediatric criteria use a bronchoarterial ratio greater than 0.9. Third, optimize airway clearance techniques as the foundation of management, combined with prompt treatment of exacerbations using targeted antibiotics. Fourth, consider long-term azithromycin for children with frequent exacerbations, and always pursue early eradication if Pseudomonas aeruginosa is isolated. Finally, investigate for underlying causes including cystic fibrosis, primary ciliary dyskinesia, and immunodeficiency. We hope this case-based approach has enhanced your clinical understanding. Please follow Pediatric Case Review for more informative presentations on pediatric conditions. If you have any questions or topics you would like us to cover, please leave a comment below. Thank you for watching.